When I agreed to do this, I had no idea. You guys, this is a lot of people. It's a little intimidating, a little bit, so don't look at me too much. Just look at them. But I am Dr. Shannon Clark. I am a professor at University of Texas Medical Branch in obstetrics and gynecology and maternal fetal medicine. So I'm kind of moderating here, and I'm representing the pregnancy aspect of our discussion. But I also have here Dr. NAMITA BHARDWAJ with orthopedics and primary care, and also primary care sports medicine, and BLAIR Brown, registered dietitian and nutritionist. So we're going to try to cover some pregnancy care, nutrition and dietary needs, and then also orthopedic and primary care needs. And full transparency though, I didn't get the memo that I couldn't wear scrubs. This is all I ever wear. But I do have to go straight back to work after this, so that's my defense. And I had to actually buy a white coat because I don't even own one. And the fit's not that great, but you know, it is what it is. We kind of came up with a name for this discussion, maintaining your superpowers through the decades, because anybody that's in this room knows that we are expected to maintain our superpowers no matter how difficult it may be with different changes in our lives and as we age. I am a twin mom at age 43. They're now 6. So I waited a little bit later, and I'm fully feeling my superpowers being really challenged right now, at almost 49 with 6-year-old twins. But everyone in this room can identify to some degree what some of the difficulties and challenges and even keeping up with our own health. When we have family members to take care of, whether it's our children, our spouses, our partners, our family members, our parents. So what I did is got with these fabulous colleagues, and there is a table on womenspreventativehealth.org. It was put together by ACOG and the Women's Preventative Services Initiative, and it's a really nice table that goes through all the preventative measures that we need throughout our lives and how they might change as we age. Now, we don't have time to go through all of this, but we're going to hit on some of the high points, and hopefully it will apply to everyone in here at some point. The first thing we're going to talk about is gynecologic care. I know. We don't like going to the gynecologist. There are a lot of incredible TikTok videos making fun of going to the gynecology visits, but you know, we've got to do it. And it used to be that we started going to the gynecologist as soon as we became sexually active, well, no matter what age that would be. That means getting STD testing, getting pap smears, but that changed. That's when the biggest, I feel, changes in primary care and obstetrical gynecologic care that I've seen in my 22 years of practicing medicine is that now we don't start pap smear screening for cervical cancer until age 21, regardless of sexual history. Now, individuals can go earlier than that if they have other needs that might be related to gynecologic care, but no pap smears before then. Then that's obviously going to change according to your age, any family history of cervical cancer, and then any other medical comorbidities you might have as you age. But the bottom line is this, it kind of changes according to all of those things, and the gynecologic annual visit is kind of largely been centered around pap smears. But it doesn't have to be that. If we have other needs that we need to go see either a primary care doc for gynecologic needs or an OBGYN, we can certainly do that. So it's important to know what's expected regarding gynecologic care, and especially getting those pap smears initiated as we age, so that we can make sure we keep up with those appointments despite how busy we might be in our everyday lives. So I wanted to turn to Dr. BHARDWAJ, or NAMITA. We're going to go by first names here. We decided this earlier. I touched a little bit on, you know, pap smears and how we do the gynecologic care, but as far as primary care, this is something we don't talk about as much. How often, when do we start going to the primary care? How often? What are some of the things that we should expect when we go to these visits?
So from my perspective, I think you should try to see a primary care physician at least once a year. And it's just more so to say, hi, how are you doing? Get your blood pressure checked. When you do come in for an office visit, we will check your vital signs, get a sense of your blood pressure. Most high blood pressure in women is actually diagnosed because they don't have symptoms. It's just taking a simple blood pressure measurement. We will also kind of go through your history, your surgical history, and then also look at what preventative care gaps do you need. Do you need to get checked for diabetes? Do you need to get checked for your cholesterol? Now the CDC recommends that everyone over 18 get a hepatitis C screening done once in a lifetime because of the risk and the benefits of medications now. So it just very much varies, but at least once a year we would like to see you. And then also when you need us, we are here for you. We would rather see you sooner than later. Oftentimes, I know as women, we like to push off our health care in favor of our family, our work, and then it becomes a bigger problem. So we would like to see you sooner rather than later in regards to problems, but at least once a year.
Yeah, and some of the other things when we talk about going to gynecologists and then also seeing our primary care doc. Some of the things we do are the screenings for breast cancer, cervical cancer, potential uterine or endometrial cancer if there are symptoms like irregular vaginal bleeding or any pain with intercourse or anything like that. Those things that can be assessed at these visits, but if you happen to be at your primary care doc, bring it up to them. Sometimes people want to wait until they think they're at their appropriate doctor to bring up that specific problem, but what we need to do interdisciplinary-wise is be ready for anyone of reproductive age and beyond to ask certain questions that may not necessarily be related to why they're there to see us, so that we can direct them into the right position, or right physician or other healthcare provider. And that also means that we have to ask as well. So even if you're seeing a family practice or primary care doc, they can still ask about how are your menstrual cycles? Are you having any issues? Are you having any pain with intercourse? Are you having any other gynecologic type issues? Well, maybe they can address it and maybe they need to send you to someone like myself. So it's okay to bring up these things to any physician because if they can't help you, they should be able to direct you or tell you where to go to get the help that you need to figure out what's going on. Let's go to Blair.
Okay.
Nutrition and dietary needs. That's something that I feel like people think they have a good grasp on.
Oh, absolutely.
We all know, right? Because we've Googled a lot.
Yes.
Yeah.
Yes.
So we all know what's the best to eat, all the different supplements, but just tell us, from someone who's an expert in this, what are your recommendations on when to assess nutrition and dietary needs? And then if you can touch on, are there certain supplements that we should be taking or avoiding with different age groups?
Yeah, absolutely. So there are more physicians than there are registered dietitians. And so usually when you go to the doctor, I am not a person that you normally see unless there is an issue. Usually obesity, diabetes, heart failure, usually that's when you see a dietitian. But actually at our institution, you can actually see a dietitian in an outpatient setting in the PCP clinic. You can get a referral for a dietitian for any needs. So if you've got any questions about anything. And nutrition is so diverse and such a dynamic field, and it differs for everybody. So what works for person A is not necessarily going to work for person B. And so with women in healthcare, and as we age, whether you're pre-conception, whether thinking about having children, or you're currently pregnant, or you're in perimenopause or menopause, or you're now considered a geriatric category, the word no one likes to hear.
Pregnancy over age 35 is considered geriatric on some ICD-10, but we won't go there.
No, I like to.
I'm sure you guys. Yeah.
I like to tell my patients.
I was a geriatric pregnancy.
I like to tell my patients, you don't get older, we get wiser in my clinic.
Yeah,
So
that's
we
true,
just
that's
gain
true.
wisdom through the years. We don't gain years.
Yes. So nutrition varies for each one of those stages. So I could be here for hours talking about each one of those areas, but particularly women of childbearing age should be really focusing on folic acid, and I think we're going to talk about that in a little bit. And as we get older, vitamin D and calcium are so important. Now, do you need to go out and spend thousands of dollars on all kinds of supplements? No. Oftentimes, your body expels those out through your urine, so you actually have very expensive urine by doing that.
Yes.
Yeah. So, and I've seen some harmful effects of taking too many supplements as well. So I think before you start any type of supplementation, you need to ask your primary care physician, OBGYN, or dietitian if you have access to one. I think that's very important.
Yeah, and I'm glad you brought that up. Many of you may not know I do a lot of education on social media, and that's one of the things I talk a lot about. Because the social media, although it's a great thing, and we know that our patients get medical information from social media, whether we like it or not, it is what it is. But there's a lot of opportunity for supplement companies, what we call influencers, to make individuals think they need to be taking this supplement and that supplement for their fertility, their egg quality, their bone health, their anything. And if you were to take everything that's recommended, we'd be taking supplements all day long. And more is not necessarily best. We have to be very picky and decisive about what we take and make sure that it's coming from a vetted source and that whoever is kind of in charge of your health whether it be a PCP or the OBGYN, knows what you're taking. And a lot of people don't even consider supplements as a medication, but we need to know anything that you're taking, even if it's a supplement, because that could interact with other medications. It could interact even with trying to conceive, believe it or not. That's a whole other discussion. So it's still important to keep, when you're doing your list of medications, include any supplements that you're taking. Would you agree?
Absolutely.
Yes. One thing I was going to mention, the whole geriatric thing about the over age 35, I'm still a little bitter about that, even though I've been doing this for 22 years, but when it was finally me, I got a little irritated. So if anybody could think of a better way that we can term pregnancy over 35, you meet me afterwards and maybe we can do something about that. But okay, so the other thing I wanted to touch on next would be depression and anxiety screening. Thankfully, and Dr. BHARDWAJ, maybe you could add into this, it's becoming much more acceptable to discuss mental health and anxiety and depression. It's not as taboo as it used to be. It is part of our overall health. There shouldn't be any taboo around it, but unfortunately sometimes there is. But would you agree, are we doing a better job in general of bringing awareness to this topic?
I think we definitely are. So as part of your actual annual exam, and actually at most office visits, we are supposed to screen you with a patient health questionnaire, 2 questions. It's called a PHQ-2 for short, and it's a quick, short screening to identify if you are at risk for anxiety or depression. And if you trigger positive on that questionnaire, we will do a little bit more of an extensive questionnaire in regards to that. So more and more people are being comfortable being asked, and we also want you guys to be comfortable asking us that, hey, I'm not doing well. Let us know. We are here for you, whether it's your OB-GYN, your dietitian, everyone, all of us know that we can direct you to the resource if we cannot help you ourselves.
Yeah, our mental health is just as important as our physical health. It really is. There's no distinction. It's a part of the whole being, and it's part of the way we maintain our superpowers, if you will, is mentally, emotionally, physically. So we need to address all of those aspects. And in pregnancy, which is when I see, obviously, all my patients are pregnant, we do the same thing. We screen pretty much at every prenatal visit, and it's extremely important as one of the leading causes of death in pregnant and postpartum individuals is suicide. And September is actually National Suicide Awareness Month and Prevention Month. So I just want to share with you, and I'm not trying to bring things down, but it is something that we all need to know and discuss because it is a huge impact on our care and our health. I'm just going to share a few stats, and I couldn't remember them, so I'm going to read them off here. So suicide statistics reveal that females are roughly 3 times more likely to attempt suicide, though men are 2 to 4 times more likely to die by suicide. So when we do these stats, we do compare a lot between females to males. The differences in attempts and completed suicides in females have erroneously led many people and healthcare providers even to believe that suicide attempts in females are often a method of getting attention rather than a serious risk, but this is not true. Anyone that has had a suicide attempt is much more likely to actually die by suicide at a later date. So we have to take suicide attempts very seriously in females. Major depression is a cause for suicide attempts and completed suicides in both males and females. So any history of depression has to be taken seriously. And then finally, women or females are twice as likely as males to carry a diagnosis of major depression. As I said, and although completed suicide occurs much more often in males. So this goes along with a screening for mental health. And I want to make it, if one thing I want to get clear, I'm very, very passionate about talking about mental health because I want to make sure that everyone knows it's just as important as if we have a broken leg, if we need to change our diet. Medications, even medications for mental health disorders and pregnancy, I am constantly fighting this fight that if you don't have a mentally well pregnant individual, you cannot have a healthy pregnancy or fetus. We have to be willing to treat, and I see all the time, and you probably have seen it too, as soon as someone becomes pregnant, thank you, yes, it's just as important. As soon as someone becomes pregnant, they're told by even psychiatrists, stop your medications. That cannot be done. It should not be done. I've seen too many people spiral because they come off these medications out of fear, and when the best thing to do is you can reevaluate what medications they're on in pregnancy, to tweak them a little bit if necessary, but if they need the medications, they need the medications. Would you agree, Dr. BHARDWAJ? Yeah.
Yes.
It's very, very important that we address this in pregnancy, and we're getting the message out there. Diabetes screening. You talked about, Blair, that you see a lot of people for nutrition for diabetes. Tell me a little bit about what that kind of visit is like for like a new diagnosis of diabetes.
Okay, so for those of you who don't know, there are two different types of diabetes. Type 1 diabetes is where basically your pancreas, which is the organ that secretes the insulin and helps bring your blood sugar down to manageable levels. Type 1 diabetes is where the pancreas does not work at all. And that's often diagnosed at a much younger age, often before you hit your teens. It can be diagnosed later on, but it's most likely more what we call, it used to be called childhood diabetes. So type 2 diabetes is what often you're going to see more in adulthood. And this is where the pancreas kind of starts slacking at its job. It doesn't secrete insulin as well. And so this is where you're going to see spikes in blood sugar. It's often characterized by individuals who are carrying excess weight, particularly in their abdomen area. But some people don't have that. But if you have family history, I think, of diabetes, you should be screened for that. And usually you will see a dietitian. An endocrinologist is the name of someone who specializes in diabetes, and usually an endocrinology office will have a dietitian. UTMB, we have a special, a dedicated dietitian just for diabetes. Her name is Lynn, and she's fantastic. And in this type of visit, we're going to go over everything. Diet, physical activity level, and diet is going to include all meals, snacks, beverages that you're drinking, and then any type of, again, supplements that you may be taking. We'll talk about physical activity levels. And so in this, you're going to have more than one visit with the dietitian because there's a lot to cover. And to manage blood sugars, it can be a lifestyle change. So you're not talking about just one quick visit with a dietitian and then you're good to go. It's going to be a huge lifestyle change. And with type 2 diabetes, it may be needed to be managed with medications as well. So one of you want to cover medications as well?
So as part of that annual physical exam, depending on your risk factors, we may screen you for diabetes with a lab test that's called a hemoglobin A1C. Depending on what the level reads for the hemoglobin A1C, if it is super high, we might need to start you on insulin right away. It does not mean insulin is a permanent solution for a type 2 diabetic. More often than not, most people come in early enough that we can actually just start them on oral medications and then get them into BLAIR to kind of have the discussion about how do I live a healthy lifestyle and how do I adjust to not have issues in the future. A question that I often get is, can I ever come off my diabetes medication, or am I stuck with this for a lifetime? With healthy lifestyle changes, it is definitely an option. It might not happen for everyone, but it does not mean that you can't work towards the healthier lifestyle goals. And so that's.
I think the biggest thing is managing blood sugars is consistent carbohydrate intake. Carbohydrate is a really big word for items that, when digested, raise your blood sugar. That's all it is.
Yeah, and I'll talk about pregnancy in a second, but one of the things that I see and hear is that there's a lot of blaming when someone ends up with a diagnosis of diabetes. And while there are things that can be done to help prevent it, there's some things that can't be done. Genetics play a role. And we have to stop looking at people and saying, well, it's your fault you got diabetes because you don't eat well or you're not active enough. They may not be, but it's not going to help them get to where they need to be. So as healthcare providers, I know I've heard a lot of stories where there is some shaming and some blaming by a healthcare provider, and I want to say here that should not be done. So if it's ever happened to anyone or someone you love, that should not be done. That's not fair. We can educate and counsel and help, but shaming and blaming should not be part of the conversation. Diabetes is hard enough to deal with without adding that to the equation. So what are your thoughts on that? Have you heard stories, Dr.? Yeah.
Yes, I definitely have. And yeah. I view the relationship with the patient as we are teammates. We are on the same goal together. We are not playing against each other. So it's a concept called shared decision making, and it's talking to your patients and being like, hey, this is some of the things that might have contributed to the diabetes, but let's get them under control. Let's see what can you do. I like to work with my patients, and I tell them about small changes that they can make. One of the I ask them, hey, what is your favorite food at the grocery store, like your favorite bad food? And sometimes people will say it's donuts or potato chips. So I just tell them, hey, for the next month, no potato chips in your house. because it's out of sight, out of mind. But it's one small change that they can make, and they can tell their family members, this is why I'm not bringing in potato chips in the house, because I want to get better. And it's not a blaming or shaming thing, it's just I'm trying to be better. And in order to get more exercise in, I tell people, hey, do you like getting dents in your car? No one really does. And so, hey, park your car far, far away. And then you can actually not get the dents in your car, but you're getting in your steps to help increase your exercise. So small changes. No one's expecting you to go run a marathon if you're a couch potato, but little small changes, talking to your patients and talking to your doctor, are positive. We want to go for progression, okay? So we want to keep and help you sustain those changes.
Those are all good points, and I am going to have you talk to my mom, because she does not listen to me. My mom is diabetic, and I've told her the same thing about not bringing certain foods, and it's not gotten through, but maybe I will have you. And I love my mom, but she is a little stubborn. But yeah, we'll talk after this about, maybe you can call my mom for me. But I want to talk a little bit about pregnancy. Diabetes and pregnancy is definitely something that is very, very common, whether it be pre-existing diabetes or gestational diabetes. And I just got in a little tiff on social media with actually an OBGYN who said that if you get gestational diabetes, it's your fault. Yeah, you can imagine how I said this to thousands of people. And that it's 100% preventable. Gestational diabetes in pregnancy is not 100% preventable. If you have a placenta, you can get gestational diabetes. If you're a marathon runner and get pregnant and have what we consider a great weight, you could still get gestational diabetes. So again, that goes along with the whole shaming and blaming. If you get diabetes in pregnancy, I want to get rid of that, because if you have a placenta in pregnancy, which everyone does, you can get diabetes. So we do screen every individual depending on risk factors on entry to care. And then if you don't have those risk factors, then between 24 to 28 weeks, they'll get screened for gestational diabetes. It's very common. It doesn't always require insulin, but it is something that has to be addressed in pregnancy, because untreated diabetes in pregnancy can have severe consequences on both the patient and the fetus. For those that are pre-gestational diabetics, having good control going into the pregnancy is ideal. So if you or a family member is contemplating pregnancy as a diabetic, having good control, again, is ideal and the best way to enter the pregnancy. Because I'm a high-risk obstetrician, a lot of my patients, we can talk about this now, actually, they don't have care unless they're pregnant. They do not have any kind of medical coverage, so I get a majority of my patients that come in not having had any care until they get pregnant. And we're playing a lot of catch-up. And so that goes along with some of the health disparities we see in individuals, especially in pregnancy. And we do what we have to do to get caught up, but sometimes we're able to do that, and sometimes we're not. But some of the things we've talked about, going to the PCP, going to the dietitian, we have to acknowledge that that's not available to everyone, unfortunately. It's really not. And for those of us that are able to do that, we're all very lucky and we're all very privileged to be able to do that, but we have to know that some of our colleagues in life don't have that option. Do you want to talk about that, Blair? Because I know I've tried to get a lot of my patients in to see a dietitian, and it's not always easy.
It's not easy, and that's one thing I wish I could change about the healthcare system as well. I always tell people, when you get pregnant, that's not the time to change your lifestyle or your habits or your health. It's before all of that. There's so much that goes into it before. So I think the biggest thing is, if any female, any male should just be established with some sort of healthcare provider if possible. And there are if you don't have insurance, there are lots of free resources out there. I think if you're looking for nutrition resources that anybody can access, the choosemyplate.gov is a great resource to start. So if you haven't looked at it, replaced the old food pyramid back in the day when we probably were all in school. This is called Choose My Plate, and it has amazing resources. You can go and put in your age and your height, and it'll give you kind of a general idea of what your healthy diet should look like for you. Now keep in mind, if you have any type of medical comorbidities or anything of that nature, it's not going to take into account, but for overall general health, I think that's a great resource that anybody can access.
That actually is a very good resource. I've looked at it before, and it is choosemyplate.gov, right? Choosemyplate.gov. NAMITA, I keep,
It's okay.
so I was going to call you NAMITA, I keep talking Dr. BHARDWAJ. When you're seeing reproductive age individuals, what are some of the things that family practice docs, internal medicine docs, when they're seeing those that could potentially become pregnant and they know they're at risk, what are some of the things that can be addressed to help get those patients where they need to be for when they do become pregnant?
I know we were planning on talking about it a little bit later, but doing like the folic acid supplementation, getting into an exercise habit routine, and again, small changes, again, not looking for starting a marathon in a week, nothing like that. But I believe the recommendations is about 150 minutes of exercise for a week on most days of the week. And so we do want you to be active, but it's active is relative. So if you are mainly, again, sitting on the couch, moving and taking the stairs and doing small steps, that is still a form of exercise. And just trying to optimize those health habits before they do become pregnant and go from there before they see
Yes,
you.
and since we brought up folic acid so much, this is National Folic Acid Awareness Week. I had the honor of being chosen by the CDC to do a webinar on Wednesday to talk about folic acid supplementation for those who are of reproductive age, as well as it's also the 30-year anniversary that the United States Public Health Service put out their folic acid recommendation, and then shortly after is when food fortification with folic acid was initiated. So again, myself being on social media, and trust me, it's a lot of work. I do it mainly to combat a lot of misinformation surrounding those of reproductive age, and it's gotten a little out of control because there's a lot of misinformation out there. But I feel like hopefully I'm making some headway, but folic acid is one of the most, believe it or not, one of the most controversial topics that patients of reproductive age or individuals of reproductive age discuss within different groups on Facebook and Instagram. The recommendation is anyone that could potentially become pregnant should be consuming 400 micrograms of folic acid supplementation daily. And that's in addition to any fortified foods, because on average, anyone that's taking any kind of fortified or enriched foods is only getting about 140 micrograms. The 400 micrograms initiated at least 1 to 3 months prior to conception is likely to raise your red blood cell folate levels high enough to prevent neural tube defects. Folate deficiency in pregnancy is known to cause neural tube defects, which can include anencephaly, various lesions of the spine. Some are treatable, anencephaly is not, but some can be treatable, that some are not treatable, and will not result in a live birth or a neonate that goes on to survive. So this is a very serious topic, and it's folic acid, which is actually very accessible and very cheap. It doesn't take a lot to make it, is very available, and it can make a huge impact on pregnancy outcomes. So folic acid is the best way to get a folate supplementation to help prevent neural tube defects in pregnancy. However, there's a lot of alternative medicine practitioners, naturopaths, and even dietitians, who will suggest other forms of folate with no evidence. There's never been any trial in pregnancy that shows that any other form of folate besides folic acid will help prevent neural tube defects. So it's important to know that methylfolate, if you've heard of methylfolate or 5-MTHF, or any of those designer prenatal vitamins that promote that, that's not what's going to prevent neural tube defects. Or let me back up. We don't know because there's never been a study. And it's not something I'm willing to gamble with my patients. Folic acid supplementation, 400 micrograms daily, is what is recommended at baseline for anyone who can become pregnant. If you have risk factors, then you want to do a higher dose starting 1 to 3 months prior to conception, and you want to continue that at least through the first 12 weeks of pregnancy. By that time, the neural tube has closed, and hopefully any defect has been avoided. So it's very important that there are certain risk factors. Hispanic individuals are at much higher risk of getting neural tube defects based on ethnicity, and also based on the fact that a lot of the foods they eat are not enriched with folic acid. So recently, I think it was in 2017 or 2016, a voluntary fortification of corn masa with folic acid was approved, but that's voluntary. So if you want to know whether or not your food is enriched or fortified with folic acid, it will say enriched on the label, and it would be in the nutrition facts or supplement facts label. That's another thing. Recently in January 2021, our nutrition and supplement facts labels on any supplement or nutrition product, food product, has changed. Mm-hmm. So if you go to the FDA, you can look at how to read the new nutrition facts label and supplement facts label, so you know exactly how to read it and what it means, especially when it comes to getting folic acid. And I wanted to talk to you, what are some of the best dietary ways to get folate or enriched foods with folic acid?
Yeah. So we've used the word folate and folic acid kind of interchangeably, and so folate is the natural form. It is actually vitamin B9, so if you see vitamin B9, that is folate. Folic acid is the synthetic form of folate that would be added to foods. So if you hear those terms interchangeably,
Yes,
it can get confusing. Am I getting folate? Am I getting folic acid? The same thing, just one is a natural form.
But the nutrition facts label will say folate.
Yes.
But then it'll include what type of folate. Under the new, or it's called dietary folate equivalents, but what you want to see if you're trying to conceive or pregnant is folic acid in parentheses. If it says anything else and it doesn't say folic acid, then that supplement does not have folic acid.
Doesn't help. No,
Yeah.
no. So some of the foods that you may want to add to your diet if you're trying to increase your folate: dark leafy green vegetables, so spinach, even Brussels sprouts, broccoli counts as one of those, sunflower seeds. Eggs has a folate content. Sunflower seeds is another one. Beans, different types of legumes, also are high in folate as well. So.
Yeah, so getting your natural dietary food folate would be the best way to get your folate while trying to conceive and pregnant. But studies have shown that, number one, up to 50% of pregnancies are unplanned, and most individuals of reproductive age do not get enough folate through diet. That's why the folic acid supplementation, on top of that, when trying to conceive and during pregnancy, has been recommended. So sometimes we, like I said, sometimes we think we eat very well, and if we really look into it, we may not be getting everything that we need. So even though I think there's a role for a nutrition visit for anyone, right? Would you
Yes.
agree with that, NAMITA?
Yes.
Yeah, I mean, even though we think we might be doing well, maybe every now and then kind of check in and make sure that we're on the right track. Great.
I'll add too is that individuals that drink a lot of alcohol, whether you're considered to be an alcoholic or not, if you drink quite a bit of alcoholic beverages, alcohol metabolism interferes with folate absorption. So if you do drink alcohol on a regular basis, you should be adding folate-rich foods back to your diet, either diet or supplementation to replenish that.
Yeah, and continuing on with the whole healthy diet and activity counseling. I'll start with the pregnancy. It's hard when someone's coming in and either A, they're used to being at a certain weight and they're gaining weight all of a sudden with the pregnancy, or they're gaining more than what their family member thinks they should be gaining, or even what ACOG guidelines or their obstetrician thinks that they should be gaining. There's a lot of pressure on a pregnant individual and their weight. And it's so hard. I see patients really struggling with that. And so sometimes it's hard to address that topic, especially in pregnancy. But what about in those who aren't pregnant? And you guys could both start with Anita. It's hard to talk about this with our patients.
It is. It's
Yeah.
a lot of times people feel uncomfortable getting on the scale at the
Yeah.
doctor's office. I have seen little cards that people can give, like, "Hey, please don't weigh me." Just to give you from a doctor's perspective, sometimes we do need to know a weight because some medications are weight-based dosing. So it is not as a way of the shame and blame. It is a medical reason we might need your weight. But if you don't want to get your weight taken at the doctor's office, you can politely decline. Your doctor may just have a conversation about it, but just to do that. And then it's just approaching them with, hey, when you are either overweight or obese with the different BMI classifications. So an overweight would be a BMI of 25 to 30, and obese would be a BMI greater than 30. It's just having a conversation and just being like, hey, when you have all this weight, it can put you at risk for different medical conditions such as diabetes, arthritis in your knees. It can cause different lifestyle changes. So, hey, let's intervene early before you develop a complication so that way we can get you to a healthier weight. But again, we're traveling the journey with you. We are not traveling against you or shaming or blaming. And if you falter, we are there to help you get better. And then getting a nutritional advice on how to make those healthy changes. It's very daunting. I didn't know about the sunflower seeds and folic acid, so that's a fun fact I learned today. So just kind of knowing kind of what you can do to optimize your diet in terms of exercise can also be very helpful.
Yeah.
What about you, Bella? Do you, when they're coming in for nutrition counseling for whatever reason, is addressing weight ever something that's on the table during those discussions?
So it's actually in the dietetics community right now. Weight is this big topic, controversial topic about healthy at every size is a big movement in dietetics. And I always like to remind patients, particularly females, we get like attached to this number of this ideal number of what we should weigh, and then it just becomes like almost kind of an obsession of what, we're defined by this number. You are not defined by your weight at all. You are not defined by your weight, okay? Everybody's body type is different.
Yes.
We use BMI as an indicator. I don't think it should be the sole indicator, but
Exactly.
there have been so many studies that show that if you have a BMI greater than 30 or greater than 35, you're at risk for developing all of these comorbidities that come along with that. Does that mean you may get those comorbidities? No, but it is our job as healthcare professionals to put that on your radar so that way we can explain this is why we're screening you for these things, because on a BMI scale you're more at risk. So if anybody has ever shamed you or for your weight, I sincerely apologize, because again, you are not defined by that number. From a diet standpoint, I mean, there's so many different things. Some people have been what they consider heavy all their lives. Everybody's body type is different. So my job as a dietitian is looking at your diet overall. What are some areas we can improve on? So what are some areas we can improve on? Are there ways we can get you to be more physically active? So I like to work with the patient, and like you were saying, like, what's your biggest or your favorite food? Okay, mine's ice cream, right? So if I have ice cream in the home, I'm going to eat it. Yes, the dietitian eats ice cream. Yes, I also love Whataburger as well. So there you go, the dietitian eats Whataburger. So I like to meet patients where they are.
Yeah. I mean, I think we need to, the BMI is used a lot to calculate X, Y, and Z and risk, and for research studies, we look at different categories of BMIs. And there's a huge push and a kickback from society in general to get rid of the BMI. Unfortunately, we don't have a better measurement yet. Hopefully one day we will. But we still have to, as physicians, take that as the whole person, not just the number of what the BMI is. Someone with a BMI of 35 may not, in fact, be obese. It might be their body type. And so we have to look at the whole patient rather than what's just in the computer. Our patients are not what's in the computer, it's who's sitting in front of us. So we have to talk to them to see, like you said, what their diet is like, what their exercise level is like, before making any assumptions or conclusions about what that BMI means. So we have about 4 more minutes left. I wanted to conclude with this one thing. I was going to stop with urinary incontinence, but I'll save you that if you want to talk to me about that later, but it's still an important topic. Let's talk about fall prevention and osteoporosis. NAMITA, just go over, this is kind of in your wheelhouse here. What do individuals need to know about fall prevention and its relation to osteoporosis?
Okay. So fall prevention, I kind of view as, it's another one of those questions that they ask at the doctor's office, have you fallen in the last 6 months that required medical attention? Yeah. The reason we bring it about is because hip fractures and, most osteoporotic fractures happen as a result of a fall. So that, if you get a hip fracture, distal radius fracture, fractures in your bones and your pelvis, it can lead to your loss of independence later on in life. So I kind of want you to view that with that hat on, not as they're just saying that I can't walk anymore and I need a walker. It's more so we want you to be as independent as possible. So the reason we ask about fall risk, because oftentimes the first time that a woman is diagnosed with osteoporosis is secondary to having had a fracture. We normally don't start screening for osteoporosis till you're 65. But if you've had a hip fracture due to a fall that typically would not cause a fracture, so for example, like you tripped over a hair dryer cord and then you broke your femur, which is your thigh bone, that is actually a sentinel event to, signaling that might be osteoporosis. Osteoporosis is a sign of thin bones, so it's in weaker bones. So there's things that you can do when you're younger, such as doing weight-bearing exercises, calcium, vitamin D supplementation, that can help you have stronger bones. Hey, but if I'm looking at a person I'm 50, 60, I have a lot of wisdom now, what do? You can do weight-bearing exercises to help build your muscle, which help build your bones. We can do that DEXA scan as part of your annual exam to get a sense of where you lie on how strong are your bones, so that we can prevent fractures and we can start you on medications. And then the goal with starting you on medications and doing physical therapy is to help you keep your independence. So that's the main goal with fall prevention, is to keep you as independent as possible and enjoying your life.
Quality of life is so important. There's many ways that we can improve our quality of life. not just health, with our health, but in so many different ways. But we're here to talk about health, so we want you guys to maintain your superpowers in as many ways as possible. I hope this talk was good for you and you learned a little bit of something today. Maybe in the future, if you guys have any other questions, we're all available through the UTMB email system if you want to email any of us, and we'll be happy to answer those questions. But again, thank you so much for having us, and I know you guys are going to have a fabulous
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.